Long-term effects, LBBAP versus bicameral leadless pacing. What are the long-term effects on QRS duration, LV activation time, and ventricular remodeling indices, LVEDV, LVEF, scar progression by CMR for LBBAP versus bicameral leadless pacing, and how do these relate to heart failure hospitalizations and atrial/ventricular arrhythmias? Answer. This question addresses a critical comparison between two advanced pacing modalities that represent different physiological approaches to cardiac stimulation. The long-term outcomes differ significantly due to their fundamental mechanisms of ventricular activation, QRS duration, and LV activation time. Left bundle branch area pacing (LBDAP) demonstrates superior performance in maintaining physiological ventricular activation. Studies show that LVEDV consistently achieves QRS durations between 110 to 130 milliseconds, with minimal widening over time, typically less than 10 milliseconds increase over 2 to 3 years. This stability results from direct engagement of the left bundle branch or adjacent conduction fibers, enabling rapid transeptal activation and near-physiological left ventricular depolarization patterns. LV activation time with LBEAP remains consistently short, typically 70 to 90 milliseconds from stimulus to peak left ventricular activation on electroanatomic mapping. The paced QRS morphology resembles right bundle branch block rather than the left bundle branch block pattern seen with traditional right ventricular pacing, indicating successful left ventricular conduction system capture. In contrast, bicameral leadless pacing systems, such as the LVEDV with both atrial and ventricular components, produce wider QRS complexes, typically 140 to 160 milliseconds, because ventricular activation occurs through myocardial cell-to-cell propagation from the right ventricular septal pacing site. While this represents an improvement over right ventricular apical pacing, it lacks the rapid conduction provided by the His-Purkinje system. Long-term data suggests potential for progressive QRS widening in some patients due to evolving conduction abnormalities around the pacing site. Ventricular remodeling indices. The differences in activation patterns translate into distinct remodeling trajectories. LBBAP maintains or improves left ventricular ejection fraction, LVEF, in patients with preserved baseline function, with studies showing LVEF changes of +2% to +5% over 2 to 3 years in patients with bradycardia indications. More dramatically, in patients with reduced LVEF and high pacing burden, LBBAP has demonstrated improvements of 8 to 12% in LVEF, comparable to outcomes seen with cardiac resynchronization therapy. Left ventricular end-diastolic volume, LVEDV, remains stable or decreases slightly with LBEAP, particularly in patients requiring high ventricular pacing percentages. This contrasts with historical data on right ventricular pacing, showing LVEDV increases of 10 to 15 milliliters over similar periods in pacing-dependent patients. Bicameral leadless pacing produces more variable remodeling outcomes. In patients with intermittent pacing needs and preserved baseline function, ventricular remodeling is minimal. However, in pacing-dependent patients, there is risk for adverse remodeling similar to traditional right ventricular pacing, though potentially attenuated by the more favorable septal location. Studies suggest LVEF decreases of 3 to 7% and LVEDV increases of 8 to 12 milliliters may occur in high-burden pacing patients over 2 to 3 years. Regarding scar progression by cardiac magnetic resonance, CMR, data remains limited for both modalities. Initial reports suggest LEAP does not induce new scar formation in most patients, though focal septal enhancement at the lead site may be observed. Bicameral leadless systems show minimal new scar formation, but longer-term CMR studies are needed to fully characterize this aspect. Heart failure hospitalizations. The relationship between pacing modality and heart failure outcomes depends critically on baseline left ventricular function and pacing burden. In patients with preserved LVEF requiring infrequent pacing, both modalities show similarly low heart failure hospitalization rates. For high-burden pacing patients, greater than 40% ventricular pacing, LBBAP demonstrates superior outcomes. Meta-analyses suggest heart failure hospitalization rates of 3 to 6% per year with LEBAP compared to 8 to 12% per year with conventional right ventricular pacing in pacing-dependent populations. While direct comparative data between LBBAP and bicameral leadless systems is emerging, the physiological rationale strongly favors LBBAP for preserving cardiac function in high-burden scenarios. The benefit of LVEAP in preventing pacing-induced cardiomyopathy translates directly to reduced heart failure hospitalizations. Patients who develop significant LVEF reduction with conventional pacing often require escalation to cardiac resynchronization therapy or other heart failure interventions, whereas LVEAP may prevent this trajectory. Atrial and ventricular arrhythmias. Arrhythmia outcomes show interesting differences between these modalities. Bicameral leadless pacing provides the theoretical advantage of maintaining atrioventricular synchrony, which may reduce atrial fibrillation incidence compared to single-chamber ventricular pacing. The LVEDV system's ability to sense and pace both chambers while minimizing ventricular pacing through managed ventricular pacing algorithms represents a significant advancement. However, LBBAP offers potential arrhythmia benefits through preserved physiological ventricular activation. Studies suggest that LBBAP may reduce ventricular arrhythmia burden compared to right ventricular pacing, particularly in patients with structural heart disease. The mechanism involves avoiding the mechanical dyssynchrony and abnormal repolarization patterns that can create arrhythmogenic substrate with traditional pacing. Atrial fibrillation incidence appears similar between LEAP and bicameral leadless systems when both maintain AV synchrony. The key factor is avoiding unnecessary right ventricular pacing, which both modern algorithms attempt to accomplish. For ventricular arrhythmias, LBBAP may offer advantages in specific populations, particularly those with cardiomyopathy or prior infarction. The more physiological activation pattern reduces dispersion of repolarization and mechanical stress on the myocardium, potentially lowering premature ventricular contraction burden and ventricular tachycardia risk. Clinical decision-making. The choice between LBEAP and bicameral leadless pacing should be individualized based on multiple factors. LBBAP appears superior for patients requiring high-burden ventricular pacing, those with reduced LVEF, or those at risk for pacing-induced cardiomyopathy. The physiological conduction system capture provides long-term protection against adverse remodeling. Bicameral leadless pacing offers advantages in lead management, infection risk reduction, and technological elegance. It may be preferred for patients with difficult venous access, high infection risk, or those requiring MRI conditional systems with both atrial and ventricular sensing/pacing without transvenous hardware. Emerging data will further clarify the long-term comparative outcomes, but current evidence suggests that conduction system pacing, LBEAP, provides superior physiological ventricular activation.